Good afternoon to everyone. I'm Dr. S. Armagam. I'm the president of Indian Association of Sports Medicine. I'm a professor and director of Center for Sports Science at Sri Ramachandra University, Chennai. I take this opportunity for welcoming all for the first webinar on sports medicine during this difficult time. At the outset, I'd like to thank all our international faculties who have readily joined among this the tight schedule and difficult times. And without taking much of the time, we'll straight away get on to the scientific program. And the first lecture will be by Dr. John Patricios. And it is my great privilege to introduce him. Professor John Patricios is in sports medicine for over 20 years. He is currently director of Waterfall Sports Orthopedic Surgery in Johannesburg and an associate professor in the Faculty of Health Sciences, University of Witwatersrand. He is a fellow of American College of Sports Medicine, the Faculty of Sports and Exercise Medicine, UK, and the International Sports Medicine Federations. John serves on the advisory board of the University of Washington, Seattle for Sports Health and Safety Institute. He is a senior associate editor of the British Journal of Sports Medicine and Current Sports Medicine Reports, USA. He served 2 terms as the president of South African Sports Medicine Association, and he's been associated with the various sports federations of South Africa. And he is a founder and director of Sports Concussion South Africa, Sports Concussion Consultant to South African Rugby Union, written the concussion protocol for Boxmort Injury Prevention Program, and we are privileged to have him as our international faculty, and won't be a better person to find to give a talk on this concussion. Professor John Patricios, all yours.
Thank you very much, everybody. Let me just try and share my screen. Is that coming through?
Yeah, very well. We can see you clearly, your slides, and you are very audible. Please go ahead.
Okay, perfect. Well, thank you very much for this opportunity. Difficult times indeed, but it does give us opportunities to do things like this. So wonderful to interact with colleagues from around the world. So my brief was really to look at concussion, sports concussion, a little bit of background, and then look at some of the direction we're going in terms of managing this condition. And I'm going to try and do that over the next few slides. Just get this to move. There we go. So I'm going to try and answer some of these questions, look at the definition of concussion, a little bit of the neuropathology, some of the potential symptom domains that we should be recognizing, look at, as clinicians, what we should have in place for optimal concussion care, and then look at some of the interventions in terms of managing this condition. So this is what we're talking about. Obviously, this organ, a very complex organ, and this particular one didn't belong to just anybody. This particular brain I'm showing belonged to this gentleman here. And Einstein had a lot of things to say, which we took note of. But the quote that I like most is this. He spoke about things that are mysterious, the source of all true art and all science. He said that he to whom this emotion is a stranger, who can no longer pause to wonder and stand wrapped in awe, is as good as dead. His eyes are closed. And the reason I think this is significant in the context of concussion is that it tends to be quite a mysterious condition to many people. And what is important for us as clinicians is to embrace this mystery and put together as much of a scientific approach as possible in addressing it. And there is some fear amongst clinicians and amongst sports people about concussion for various reasons. Now, the first is that there's not actually a visible wound. It's very difficult to see concussion, to diagnose it, and to provide a definitive prognosis, as we can with many of the other conditions which as sports physicians. So if you look at something like an ACL, for instance, it's quite easy to diagnose just on a history, certainly combined with a good clinical examination. And we've got investigations which definitively tell us exactly what has gone wrong. And based on that, we can tell the patient exactly what the prognosis is likely to be, offering them various interventions. And unfortunately, we don't have that with concussion. The second issue is that it's become a very prominent public health issue, very high media profile. And so we've got this condition which is difficult to diagnose, difficult to manage in many ways, and yet has a very high profile, so places us at some risk as clinicians. And so the risk is that we can oversimplify it. We can start grading concussions, we can come up with a pigeonhole approach, and that becomes very difficult. So in the next few slides, I'm going to try and illustrate how we should be evaluating concussions and putting together a more comprehensive, individualized approach to these conditions. So when I started practice in the 1990s, diagnosing concussion was a lot simpler. You only had two conditions or two criteria. One was a loss of consciousness and the other was amnesia. If you didn't have either of those, then you weren't diagnosed as being concussed. And on the basis of that, we used to grade you and put a very simple management process in place. From 2001, when the first international conference on concussion took place, our diagnosis or our definition became much broader. So we started talking about a trauma-induced change in mental state that may or may not involve a loss of consciousness. And so that really broadened the diagnosis quite considerably. So we now talk about a condition which is a traumatic brain injury that's important to diagnose. It's caused by some sort of impact to the head or transmitted to the head that changes the way the brain normally works. So it changes the function of the brain. The head doesn't have to be directly hit. There can be indirect transmission of force. And there's not usually loss of consciousness. So if you're using loss of consciousness as a criterion, you're going to miss about 90% of cases of concussion, and that's important to acknowledge. So we're really talking about this spectrum of injury here, down at the sort of minimal to mild spectrum. And in a way, that's more difficult to diagnose because we don't have those gross changes either neurologically or on imaging that we see at the more severe end of the spectrum. Also important is to realize this is not something that just happens in the big contact and collision sports, such as American football, Australian rules, rugby, etc. There are a number of scenarios in which concussion takes place. So it's very important that as clinicians, we have an approach to treating concussion because it happens in many active people. Why has concussion adopted such a high profile, and why is it important that we have this approach? And I've got 7 reasons that I think are important. So the first is that certainly at the outset, concussion can mimic more serious intracranial injuries. So you need a situation where you have a clinical approach which can monitor that individual so that we can determine whether it's at the more mild end of the traumatic brain spectrum or whether it's evolving into a more serious condition. And also to remember that athletes have other conditions. So we have athletes who also suffer brain tumors, for instance, and some of those symptoms may overlap. And we need ways of discerning and diagnosing that condition accurately. Secondly, is that in the acute situation, if that patient is not removed or protected, their brain may be subject to more serious injury. Some people call it a second impact syndrome or a sort of malignant cerebral edema, but that may evolve if that patient is not removed from the field of play, and that brain can undergo severe trauma in the acute stage. The third important scenario is that of the post-concussion syndrome, symptoms and signs that may go on for weeks or months, and that can significantly impact an athlete's day-to-day existence. And so we need to be able to monitor those and be able to intervene more effectively than we have in the past. The fourth important point is that it often affects young athletes who are in a learning environment. A lot of these symptoms are cognitive and emotional in nature, and so that can drastically affect learning. And so it's important that we acknowledge that and intervene appropriately. What we've learned fairly recently is that concussion, when not recognized and treated properly, will impair performance and increase your risk of injury. And that's very important in a sports environment, that putting a player back will not only affect their chances of a repeat concussion, but will affect their performance and will increase their chance of musculoskeletal injury. And so we need to be able to manage them appropriately and get them back when they're fully rehabilitated. And then obviously the issue which has been in the public arena significantly is that of more chronic neurological and psychological sequelae. The chronic traumatic encephalopathy type of scenario where athletes years or decades down the line had suffered neurological and psychological fallout, which has been tied in with previous concussions. So very important to acknowledge that. And then just as clinicians, I think it's very important to be credible and acknowledge that there is a spectrum of concussions, most of which are quite mild. There's also a differential diagnosis, which we need to be able to discern. And so as clinicians, we need an appropriate response or approach to these conditions. So a lot of what I'm going to say comes from the consensus meetings, which have taken place over the last 2 decades. The 6th consensus meeting was meant to take place in Paris in November, but has been delayed by about a year because of the current situation. But it's very important coming out of these meetings that we have very consistent messaging. And so we have an opportunity today to broaden the spread of that message through our colleagues around the world who may tap into the talks that are going to be given today. So let's move on to a little bit of the neuropathology. So I look at concussion as a form of brain strain. It's described as a functional injury, but there's no question that there is structural damage. It's just that we can't see it. So that structural damage happens at axonal level, where there's strain of the axons, and you might get it in the form of tensile strain, a shear strain, or a compression strain. And the extent and the depth of the damage is influenced by the duration of the acceleration and deceleration forces to the brain. But as I mentioned at the outset, this is invisible. We cannot see this because we don't have access to the sort of imaging which is going to tell us the type of structural damage that is taking place. And so we don't have the luxury of viewing what is going on at the level of the axon or the synapse. And so we have to rely on the clinical manifestations of the functional changes taking place to be able to determine the extent of the disruption of the chemical transmission across the axons. These are slides from a colleague in Boston, Bob Cantu, which I think describe what happens to the injured neuron very nicely. In the normal neuron, on a day-to-day basis, we have signals arriving at the neuron in the athlete's brain. The signal travels down the axon to another cell in a very organized fashion, and in equally organized fashion, the neurotransmitters are released and trigger the next cell with a very specific coded message. In the injured athlete's brain, what happens is you get a significant disruption in the flow of the ions into and out of and across that neuron. So during injury, potassium ions rush out of the cell and more toxic calcium ions rush into the cell, leading to metabolic dysfunction. There's a significant disruption, not only in the transmission across that axon, but across the synapse as well, where there's a massive uncontrolled release of neurotransmitters that interferes with cell communications. And in this particular stage of injury, there's not only metabolic dysfunction, but it results in what we call an energy crisis, where there's a diminished supply of glucose to a very vulnerable cell, and that leaves the nerve cell extremely vulnerable to further injury or stress at this particular stage of acute injury. Over days or even weeks, that cell usually returns to a normal function as long as it's not re-injured or overstressed. and after many days, we get a normal function of that cell again. So these brain abnormalities are associated with changes at a microscopic, cellular, molecular, and metabolic level, but they're mostly completely resolved with time and rest. And those disruptions I described are classically called this neurometabolic cascade of concussion, as illustrated on this graph over here, where you have a disparity between the metabolic requirements of the cell and the cerebral blood flow to that particular area. For my simple brain, I like to look at the concussed brain as a 5-lane highway where you've got busy traffic flow, and each lane carries a different form of traffic. So you might have cognitive traffic in one lane, emotional traffic, physical traffic, balance traffic, and sleep traffic, for instance. And what happens in the concussed brain is that you have an accident which blocks off one or more of those particular lanes. Now, what happens is if you try and rush the same sort of routine or normal amount of information through that brain with its remaining 2 or 3 lanes, you get a backup of traffic, which is often what the athlete experiences, is a significant backup and inability to function in one or more particular domain. And our role as clinicians is to really allow that traffic to start flowing again and get that athlete to start functioning in each of those domains by getting the traffic in each of those lanes to flow appropriately. Unfortunately, I just want to try and go back here. It's not quite that simple. And in fact, if you had to map out the concussed brain, it would actually look more like this, which is a very much more complex picture, but probably more accurately describes what's going on. And we don't have the time today to go through this, but I would encourage clinicians in this audience to go and look at this paper that looks at the impact of concussion at a cellular, network, experiential, and social level. And it comes from this group in Portland in the United States, and go and look up this paper. It's freely available on the internet, The Dynamics of Concussion. And Erin Kenzie's group has mapped the pathophysiology of concussion very, very intricately in the form of what they've called causal loop diagrams. And Kenzie and team have looked at it in terms of these feedback loops at an intracellular level, where they look at the impact of concussion at mitochondria, cellular energy level, etc. And in a follow-up paper have looked at how this is affected not only at a cellular level, but in terms of networks, the experience and other factors which might impact on that individual and the social context of concussion. And I would encourage you to go and look at these 2 papers, because they put the injury that we refer to as sports concussion in a very, very good context, an appropriate context, and look at it in a very detailed level. And actually it illustrates the complex type of injury that it can be potentially. So if we look at it from a clinical perspective, we can break down the signs and symptoms of concussion into different types of domains. And these may be somatic or physical, cognitive, emotional, and sleep or energy related. And you will recognize many of those symptoms. And a far cry from the 2 symptoms and signs that we used to look at in the past, we now recognize well over 20 symptoms associated with concussion. Importantly, many of these symptoms overlap with other well-described conditions. And we have to remember that athletes also suffer potentially from many of these other conditions. And those might include psychogenic conditions, malingering being one of them. And so being a team sports physician is often very, very difficult to be able to distinguish what we're doing, particularly with all the hype around concussion, because we may, in the context of an athlete suffering some of those conditions or symptoms, be dealing with something else, like a migraine or a vestibular symptom injury or cervicogenic pain or some sort of depression or anxiety condition. So very important to be able to have a system in place that distinguishes those. So how do we do that? Well, the tool that has evolved over the course of the concussion consensus guidelines that have evolved is the sports concussion assessment tool, the 5th version of which is now in circulation and the 6th version which is being worked on. And so we've evolved from guessing to incorporating a neurological exam, which in this context tends to be quite blunt, looking at balance tests, various cognitive tests, and we've got now a whole lot more parameters that we look at in terms of evaluating the concussed athlete. So one of the take-home messages is really that you need a multimodal, multi-time frame approach to managing and assessing concussion. Increasingly, we've looked at oculomotor function as an important circuit to be evaluated, and we've evolved our techniques in terms of looking at a number of ways of assessing the ocular vestibular system in particular. Another important take-home message is that we no longer just put patients into a dark room and let them rest from sport and cognitive stimulation. We now have a much more interventional approach in terms of treating concussion. We acknowledge it as a treatable condition, not in the traditional sense of throwing medication at the patient, because in fact the medications we have available are largely reactive. They treat certain of the conditions, particularly when they become lingering, when they're associated with concussion. But we have now ways of intervening in terms of assessing each of these important domains, very nicely illustrated on this chart put together by Dr. Paul McCrory, who's been one of the leaders in the field of concussion assessment. And so if we look, we've got different domains: neurological, cognitive, mood, behavior, autonomic, sleep and hormonal, cervical and vestibular. We have different ways of evaluating each of those, and we have specific interventions in the outer perimeter here, which are advocated for each of these. And you can see that this is a significant shift from the evaluation of loss of consciousness and amnesia and keeping patients away from sport for a specified time, to looking at it in a far more complex manner. So the approach has become much more individualized in terms of which areas of the brain are most affected in that individual susceptible patient. So what are those interventions? And over the last 5 or 6 years, we have a number of interventions which have been shown both in a clinical setting and a research setting to have significant benefits for the concussed athlete. So one of those is vestibular training, improving balance and making sure that that athlete's balance is corrected, not only to make them feel better, but to diminish the chances of them suffering a repeat injury as a result of disturbed balance. Then the other significant change is supervised graded exercise. So we no longer totally rest patients while they're still symptomatic, but we subject them probably as soon as 48 or 72 hours to a graduated exercise program that doesn't worsen their symptoms. So what we call a sub-symptom threshold exercise program, which is controlled and which we can gradually increase in terms of duration and intensity. And that has actually been shown to improve their return to sport timeframes and to improve their symptom scores compared to those that aren't subjected to low-grade sub-symptom threshold exercise. To accomplish this, we've moved away from the sort of team doctor on the side of the field doing a quick assessment and giving a prognosis to a much more multidisciplinary approach. And so to optimize concussion care, we really need a sports physician to manage that team, but to have around her or him a team that includes many of these disciplines. And then the athlete needs to also acknowledge that for optimal benefit, they need to bring on board their management or technical team, their family team, and if in the cases of students, an academic team as well. And so we need to be able to prepare before the concussion occurs to have these this sort of support network available. And that makes managing these athletes much more effective. As a result of the more complex, the recognition of a much more complex involvement of key areas of the brain, particularly the ocular area, vestibular area, and proprioceptive areas, you can imagine that in sports people, eyesight, sense of balance, and sense of awareness in space are absolutely integral to performance on the field and injury prevention. And we know that when we rehabilitate musculoskeletal conditions, we put all of these criteria in place in terms of our management program. And if we don't address that, what we do see is that the athlete becomes injured, not only from a concussion point of view, from a musculoskeletal point of view, more readily than if that rehabilitation doesn't take place. Where are we going in terms of technology in concussion? Well, you'll often read about, particularly on social media, the role of impact sensors, eye tracking, biomarkers, both blood and salivary, to try and diagnose concussion, and functional imaging. And those are areas which are significantly involved in research, but probably haven't quite broached the divide into regular clinical use yet. There's still too many unknowns in those particular areas. But I think coming out of the 6th consensus conference, we'll have much more information on the appropriate role of technology, both on the field and in the office environment. So, in wrapping up, some take-home messages. Concussion is a very complex pathophysiological process that manifests to us as a functional disturbance rather than the structural injury, which is very difficult to see. We need to remember as clinicians that the evaluation of the concussed athlete is a clinical multimodal process that includes a number of facets: a general and neurological examination, cognitive tests, balance and ocular assessments. That the vestibular ocular motor assessment has become a key component of not only our evaluation, but our rehabilitation of the concussed patient. That this management is also multimodal via relative rest, not absolute rest, and targeted rehabilitation techniques. And that not recognizing and appropriately managing concussions results in a predisposition to further concussions and other injuries. So I'd like to end there. Thank you very much for those who've attended, and look forward to some of the questions that will come in the next few minutes. Thank you.
Thank you, John, for an excellent lecture. Concussion is a very hot topic, and I'm sure there are going to be a lot of questions. And we'll take those questions at the end of all the lectures. I think Dr. Tyagarajan is getting all those questions. So now I request Dr. Peter Brukner to share his screen. And it's my great privilege to introduce Dr. Peter Brukner. He's a founding partner of Olympic Park Sports Medicine Center in Melbourne and professor of sports medicine at La Trobe University. A founding executive member of Australasian College of Sports Physicians. He served 2 terms as a president and played a key role in establishing sports medicine as a medical specialty in Australia. And is a co-author of a widely used book, Clinical Sports Medicine, which is almost like a Bible for this part of the world for the sports medicine, and has been a team physician for professional football clubs, as well as national athletics, swimming, soccer, men's hockey teams, including Olympic and Commonwealth Games. Today, Dr. Brukner, it's our honor to have you as faculty, and I request you to give your talk.
Well, thank you. Thank you very much for the invitation. And thank you to John for an excellent overview of concussion. When you get old like me, they stop asking you to sort of speak about specific topics that you might have researched, and they sort of ask you to talk about more philosophical issues. So as an example today, I've been asked to talk really about building physician leaders. And what I want to talk about really is the potential for the role of the sports physician to be a leader in our community, in our medical community, in our sporting community. And I'm just going to take you through a few examples of that as we go. I'm going to talk briefly about the role of the sports and exercise medicine physician, the safety of the athlete, some ethical leadership, and then a few comments on the current situation. So what about the sport and exercise medicine physician? Well, we really have a unique knowledge and training. I mean, no one else has the breadth of knowledge about sport and exercise medicine that we do. We have firsthand experience of what's going on. We're on the sidelines in sport. We know what's happening. Our primary concern is the health of the athlete, and we must always remember that. Despite all external pressures and so on, our primary concern will always be the health of the athlete. But we have a secondary concern also to make the sport safer, and that's one of the areas where I think we can have shown leadership and can show further leadership. We just heard from John about concussion in sport, and I certainly don't intend to try and match his wonderful lecture. But as he mentioned, there's been a number of concussion conferences now. The Vienna, Prague, Zurich, and more recently the fifth one in Berlin in 2016. Regrettably, this year's one has been postponed, but they've been driven by sports physicians who've really taken the lead in the management of concussion ahead of the neurologists and neurosurgeons and so on, because we are really the experts in concussion. As John said, the neurosurgeons see the severe trauma. We see the mild brain injury that we refer to as concussion. So it's imperative that we lead the way in this, in the way we're going to manage and the way we treat concussion. And as John said, we've had these excellent outcomes from these conferences. In rugby, for a long time, there's been a leadership from the sports medicine community. There was a huge problem back in the 60s and 70s and 80s with spinal injuries in rugby. And the sports medicine community got together and decided that it was time to take measures to reduce the incidence of those injuries. And so they created an awareness program with an emphasis on player fitness, neck strengthening. They amended the rules of the game, specifically in relation to the scrum, and they influenced the sport to enforce the rules of the game, with the result that while we haven't completely eliminated spinal injuries, we've had a dramatic reduction in the number of particularly scrum engagement spinal injuries in rugby. So that was a very early example of how the sports medicine community can make the sport safer for the individual athlete. Similarly, rugby has been a leader in concussion, and there are now excellent match day protocols and various protocols that World Rugby, through Martin Raftery, the Chief Medical Officer, and Simon Kemp and others, have really led the way in the management of implementing those sort of messages from the concussion conferences into the world of sport, into World Rugby in particular. Similarly with cricket, most recently, some of you would be aware that the ICC has approved concussion substitutes in international cricket, something that would not have been heard of 10 or 15 years ago. And again, that's we've had recent examples, obviously, of the use of that concussion sub. And it's really important to pay tribute to one of my colleagues, Dr. John Orchard, who really single-handedly, as a sports physician, has driven this subject of concussion substitutes. And he's been doing it for 10 years. It's been a long process, but he takes really all the credit for the fact that we now have concussion subs. So yet another example of the way sports medicine can show leadership in sport to make a sport safer. Protective equipment has been a big focus in sport, not just in cricket as we just saw, but in a whole range of sports. And again, we've been sports physicians have been driving the need for protective equipment. Getting back to cricket, I guess everything changed in cricket on a particular day at the Sydney Cricket Ground in November 2015, when a young Australian batsman by the name of Philip Hughes was struck in the neck while playing a first-class game. And the consequences of that were, as many people know, tragic. and that Philip was taken off the ground, was resuscitated very well by the same John Orchard I was talking about, was taken to hospital, lay in hospital for 48 hours in an unconscious state, and very sadly, 2 days later, passed away. One thing that showed again was that sports physician and sports medicine sort of took over the leadership on that whole process. And in Australia, I was involved with that process, and it soon became clear to me that everyone was looking to the doctor, to the sports physician, to show leadership and to take us through this very difficult period. So I became the face to the media for the 48 hours between the blow and his death. And then it had a massive impact on not just in Australia, but throughout the world. And I guess the reason for that impact was that cricket always was regarded as a safe sport. And for the first time, really, it drew to our attention that, in fact, cricket is a very dangerous sport. And it's interesting how since then there seem to have been so many more incidences of head injuries and head knocks and concussions in sport than there used to be. At the end of that, after Philip passed away, I felt it was very important to have a press conference and explain a number of issues. First of all, it was an opportunity to thank the hospital and everyone who'd helped with him. But more importantly, it was an opportunity to explain the circumstances of how this had happened and the injury and why he died, and specifically the fact that it was such a rare injury, that it wasn't going to happen to your father, your brother, your son, who's going to be playing this cricket this Saturday. And I felt that was a really important message to get across. And a lot of people subsequently said that gave them a lot of solace, a lot of relief, that because they were wondering really whether they should be letting their young son or whatever play cricket. So again, an opportunity to present to the public. And as a result of that, there's obviously been changes in helmet design, and with the guards now that have been fitted to the helmet that protect that area of the neck that Philip was injured. And again, sports physicians have been at the forefront in conjunction with engineers and the manufacturers of designing that helmet and organising that for that to be enforced. And again, we saw an example of another hit to that very similar area at the Lord's Test last year, when Stephen Smith was hit in the neck, collapsed to the ground, and everyone was very fearful because he seemed to be hit at exactly the same spot as Philip Hughes. But interestingly, Stephen Smith had always been adamant that he wouldn't wear one of those guards before. I've had numerous arguments with him when I was the team doctor, and he always said, no, I can't use it, it's too restrictive. And then sure enough, the next test, there he was with a guard. Fortunately, it wasn't his injury was not too severe and long lasting, but it forced him to make that change. And now there is talk about these guards becoming a compulsory part of the helmet. And once again, this has been driven by people like John Orchard and others who've been driving this, once again, showing sports medicine leadership in sport. And I think sports are crying out for that sort of leadership from us, the medical staff. I want to talk about a couple of interesting incidences in the Premier League, which highlight the importance of the role of sports doctors. This is a game between Tottenham Hotspur and Everton a few years ago, and I'll just show you the incident if the video will work. Hopefully that'll work. You can see there that the goalie had a collision with the player and was knocked unconscious. You can see there, copped a knee to the head. And following that, the doctor came out on the ground, obviously, and the stretcher was called. The player eventually regained consciousness, walked off the ground, and the doctor signaled to the bench that he needed to be replaced. The scary thing then that happened was that the manager overruled the doctor and sent the player back on. The manager was Andre Villas-Boas, and that was his attitude to the doctor. And afterwards, he said, I made the call to keep him on the pitch because of the signs he was giving. He was determined to continue and looked concentrated, driven and focused enough for me not to make the call to replace him. The saves he did after the incident proved that right. So a very clever man, this Villas-Boas, not only a football manager, but a doctor as well. He was able to determine that the player was okay. And there was consequences of that. In the media, both Jerzy Dvorak, who was at that time the head of the FIFA Medical Commission, and myself went to town. I wrote an article in the London Daily Mail. Bosses like AVB are so ignorant, and I sarcastically said that what an amazing man he was. They had all this knowledge, more knowledge about concussion than a doctor. And the interesting thing was that despite the manager saying he did not have concussion, the player did not play for their remaining 2 weeks. And sure enough, 6 weeks later, they sacked the manager. So I guess justice was done there, but it just showed very clearly that it's important for doctors to stand up for themselves and for each other and make sure that the pressures of sport and the pressure that these managers are under to perform, we need to counteract that with a strong medical presence. The second case that some of you may be familiar with was the Chelsea-Swansea game in 2015, where a Chelsea player, right in the dying minutes of the game, was knocked to the ground, and you can see from the photo there, probably had some clear evidence of a concussion. The doctor and the physiotherapist went out onto the ground and took the player off to the side of the pitch. The manager was not very happy with that. In fact, he was furious with it because it was a crucial time in the game, and they had to play with one player short for about 15 seconds, which upset him greatly. And he was very critical of the doctor after the game, and basically made this comment that even if you're a kit man, doctor or secretary on the bench, you have to understand the game. And the doctor was subsequently, he got a lot of publicity about that. He was very critical of the doctor in the press. The doctor was then sacked from the team, and that was the end of her career with Chelsea. And so over the ensuing few weeks, there was a lot that went on. Again, I went into the press and various newspapers around the world and spoke up for the doctor, and eventually I suggested that he should apologise. Eventually, the case went to court, and the manager was forced to apologise to the doctor. But again, the damage to the doctor's career was significant. So again, showing that it's important that we stand up to these bullies and it showed the importance of the role of not just the doctor, but also the whole sporting community. So I tweeted that a little bit after that. Villas-Boas was sacked 5 weeks after disrespecting Spurs medical staff after the Loris concussion episode in 2012. How long will Mourinho last? Well, the answer was not very long. 2 months later, he was sacked as well. So maybe it doesn't pay to actually overrule your medical staff. But again, we need to support our fellow doctors when we're doing that. And hopefully those 2 cases gave important lessons to coaches throughout the world about their priorities and prioritising the players' health rather than winning a game. And finally, COVID-19. It was interesting in the lead up to the banning of sport in my country a few weeks ago. Someone made the comment that the team doctor has become the most important person in the club, and that's probably true. And an epidemic like this, pandemic like this, highlights the importance of the team doctor. And we have a really big role to play in this, both within the team and also within the community. And I've been vocal. Again, this is an article I wrote in one of the national newspapers last week about the importance of promoting your health during this time of lockdown. So again, an opportunity to show leadership both in sport and in the community. So I hope I've just shown you a few examples of the way the sports physician can show leadership, and how important it is that we do show leadership, because people look to us as doctors for leadership in these situations. So thank you very much for having me tonight, and I look forward to discussions as we go on through the evening. Thank you.
Thank you, Dr. Brukner, for an enlightening, great talk. And now I invite our next speaker, Dr. Ahuja. Dr. Ahuja has worked as an army captain in Indian Army for 5 years in 1970s. He took part in Indo-Pak and Bangladesh War and was awarded 4 Army Service Medals for gallantry services. Then he worked in National Institute of Sports, Patiala for almost 3 decades. Worked in different specialties for preparation of national teams, scientific evaluation, nutrition, recovery, and is primarily responsible for creation of Faculty of Sports Sciences anti-doping program, starting 2 years postgraduate diploma course in sports medicine for medical doctors. He conducted various national, international conferences, Asian courses, clinics, workshops, and acted as a resource person for various academic, Asian, and FAMS courses. And he is the chairman of Asian Medical and Doping Commission. Dr. Ahuja, it's our honor to have you among us, and I request you to give your talk.
Dr. John and Dr.
Please
Peter.
unmute Dr.
Sorry.
Yes, sir. You've been on a mute mode. Sorry. Now you can start.
I think you have put me on the mute mode. You
Yes.
only have to unmute it.
Now you are live, sir. Please.
Yeah. I'll just share my presentation. Sorry. The topic which has been assigned to me, I hope it is clear now. The topic which is assigned to me is on overtraining and recovery. After having known about the various injuries, which have been very beautifully explained by the earlier experts, you see, I'm going to talk of another pertinent point, and that is, again, which is dealt by a sports physician. And in that, we have the problem of overtraining. Now, overtraining, of course, leads into a lot of conditions, and it's very, very difficult to diagnose also. But before we go into the details of that, just let's have a look of that fatigue, of course, is a stimulus, you see, and we need an adaptation after every training intensity which is given over there. So adaptation, of course, all of us, we know that it is an adjustment of the physical and the psychological functional systems which are accomplished under the influence of external loads to achieve those high performance standards in sports, which is normally the main aspect of every coach, every trainer, and the sports physician who is working on that. Briefly, we'll just...
Sorry, you can go to the play mode on your presentation, please. The keynote, if you go play mode, then the whole screen will have the slide. The top. Yeah. Thank you.
So the volume and the intensity has to be an optimum. Now that's the main problem, that we do not yet have come to any compromise in any field, in any game and sport, where we can ideally identify that what should be the volume and what should be the intensity of the load over there. But we know it that under the laws, it has to be an optimum. So much of variety of sports people that we deal it start from when they get inculcated into sports, you see, adolescent athletes, we have the elite athletes, you see, but a lot of them, they drop out because of this when the laws of the adaptation are not followed correctly or so. So the important part is that there has to be a correct interplay of the work and recovery, and that's how the adaptation process will take place. And for that, we have the main theory, which we call it as the theory of supercompensation, you see. And in this theory of supercompensation, whenever there is any training stimulus which is laid down through any training stimulus, it will lead to a reversible decompensation. And then we compensate, but we need to go into the stage of compensation, supercompensation. And then we get into a normalization. Let's have a look when we do not follow this theory of supercompensation. This looks very hypothetical, but I think it's very, very important to understand this theory, which is a well-established theory, I think, for more than 4 decades or so. I think I used to take into consideration even when I was studying in the field of sports medicine or so. Every time a stimulus comes, we need to have the optimal performance, and the stimuli have to be coming at that time so that we are having a graded approach. And when we talk of stimulus, that means we talk of whether it is during an off-season training or during the pre-competitive season or so that the stimulus keeps coming at a regular intervals, and there is an optimization of the performance which takes place also. In case it's not coming, in the second graph that you are able to see it, there is a very small increase of the performance. But the worst problem comes when we go into a state of a decompensation and there is a decline in the performance, and that is what we call it into the overtraining. A lot of researchers have tried to classify this into a stage 1, stage 2, stage 3, in a sense that probably there'll be an overreaching first of all, and then only will be going into a sympathetic kind of a training, and then there'll be probably an overtraining or so. So all these biological adaptations needs a higher level of functional organisms, economy, of course, of every organs, increased stability of these of these various organs, increased resistance to the fatigue, and that's how we follow these various steps of adaptation, which are going increasing manner as the way we graded also the exercise protocols which are followed over there. And it is for every system. It is not only for your muscular strength and for the endurance or the various small motor qualities areas which needs to be improved upon or so. So again, from this theory, we know it that the adaptation processes are released when training reaches an optimum intensity. Adaptation takes place during the recovery, and thus the theory of supercompensation or overcompensation is the main basis, and thus recovery is essential. Now, how much is that? That, of course, we will talk it over there. We will go into the various hypotheses also as to why we laid into this imbalance between the recovery and the training also. So that's the overtraining model in which we have the performance, you see, and then we have the overreaching, and it's leading to an overtrain when we do not supposed to be following otherwise the supercompensation also. It's over a period of a time that we get overtrained and all the various symptoms that starts over there. Very finally summed up also from the Boston Medical journals right back in 1920s even, you see, that overtraining or stillness is a bugaboo of every experienced trainer. It's a condition often very difficult to detect and very difficult to describe even, whether it is due to the nutrition, training load, competition stress, psychological indispositions, and how to maintain the balance between the training, sleep, work, recreation, all those various factors that we have it also. The epidemiology, if we see in overtraining, we see in our athletes, at least 7 to 20% of the athletes at any given one time, they suffer from this. And 2/3 of the elite runners over the course of the career suffer from this. Most of the sports which cover are your endurance events, practically every sport or so, but we have the swimming, running, cycling, even power sports like powerlifting, weightlifting, also seen basketball also. A lot of synonyms have been given to overtraining. You see, some people used to call it overloading, staleness. Of course, in other um, uh, events like physicians, teachers, parents, they undergo the burnout also. But confining ourselves to the sports only, and the risks that we have it as far as the overtraining syndrome is concerned, of course, the performance for which we are always concerned about it, that gets poor. The more chances of injuries that we get it over there, more susceptible to illnesses because of the compromisation of the immune system that we have it. And so much so that it may take sometimes, if we go into a grade 3 of the overtraining or so, it may take a year or 2 years even to come out of that overtraining state also. So the best will be that we need to know the various kinds of symptoms at the early stage or so and take the remedial steps. But before that, we need to know as to what are the various positive factors also for that also. The most of the pedagogical causes that we have seen over here is a training program and a periodization when it is not tailor-made. We have a group of sports people, say like in a training camp, we have 20 to 25 players coming from their homes for training, and they have different kinds of levels of fitness also. But probably the training program is not properly tailor-made, or individualized training program is not followed also. Or in case there is a sudden increase in the intensity of the volume. I'm talking from the Indian conditions, especially that we have seen it in our national camps or so, because sometimes there is a sudden changes in the competitions which are taking place. Our calendar is not properly defined or so, and result is that sometimes all of a sudden a competition is announced. Of course, we're going to have problems. We are not talking of this particular year where a lot of things are cancelled and rescheduling of all the programs shall have to be made also. Too much of technical load or a scientific load sometimes given by the trainers and the coaches, or even the physicians talking. Athlete is not at all interested in knowing what is aerobic, what is anaerobic, what are the biomechanical things, and what are the various psychological parameters. He is interested always in the performance and in training also. So too much sometimes of these kind of loads or talked over there, even that also affects the psyche of an athlete and leads into an overtraining kind of a thing. Too many failures, multiple peaking also sometimes is given. The periodization we talk of normally a double periodization or so, but there's always a problem of domestic meets, calendars which are more advanced or so, and result is that they have to participate in some of the smaller meets because of the pressure from the various sources, whether it is national federations or so. So whether it's the pressures of the national federation, sometimes media expects them to perform, the parents, coaches, peers, even the social media factors, and of course, other socio-economic causes also, whether it is the economic problems of the family or it is the parents, you see, the chronic illnesses, even that also can affect and haywire the whole complete training programs and thus affects the basic nervous system of this thing and leading into an overloading also. Sometimes because of their personal life things, you see, like love affairs, sex life, overindulgence in players, leading to a guilt or so may also be the causative factors. Idea is that the sports physicians have to know all these factors and work in tandem with the coaches and the trainers to know about it so that we don't falter it and not only the training program is faulty. So these factors also have to be kept in mind also. The types of the overloading that we see, sometimes it is due to maybe a sympathetic hyperactivity or what we call it as basidoviform overloading or an addisonide overloading due to a parasympathetic domination or so. Symptoms, of course, are so vast, and that's why it is very, very difficult to know about it. The cardiac activity, increased eating, appetite, sleep, and a whole lot of psychological symptoms of loss of initiative, restlessness, obsession, depression, and of course, as I said, that the immune system really gets affected also, and thus the susceptible to injuries and diseases. Athlete starts becoming very nagging, obstinate, and there's a less contact with the coaches, colleagues. He becomes very introvert. He's not very receptive. He's not very talkative the way he used to be bubbling with activity or so. So all his training programs. So there is a decline in the performance coming over there, and this is. And unfortunately, these are the first symptoms to develop it also, the psychological symptoms which needs to be taken care of whenever we have it over there. Physiologically, of course, well, there is a lowering of whether it is the anaerobic threshold, the lactate threshold. We will see as to what are the various hypotheses that we see it. But of course, the cardiovascular system, the prolonged pulse rate, the recovery is getting affected also. The current hypotheses that are now gaining grounds in the overtraining is the branch chain amino acid hypothesis, autonomic imbalance, as I was just telling, that is between the sympathetic and the parasympathetic overloading. Glycogen depletion also starts taking place. It is sometimes because of loss of appetite or because of increased intensity, and there is a depletion which takes place. Glutamine deficiency, again, responsible for various kinds of immunological problems leading to susceptibility to illnesses and injuries or so, or there may be a cytokine hypothesis also or so. Physiological changes that we see, of course, which can be quite easily seen is from the resting heart rate, and even the maximum heart rate that gets decreased even by 5 to 10 beats or so. A lot of researchers have tried different kinds of tests for that, but I think the heart rate variability is the most important to identify and to diagnose also in such kind of athletes who are going into a non-functional overreaching, because that's the first stage that we talk about before he going into a sympathetic overloading or going into a stage 2 or so. And some people, of course, are doing even an orthostatic test or just checking the pulse rate on resting conditions after 10 minutes of a rest, and then doing it after 15 seconds, 90 seconds, and then 120 seconds or so. And in case the pulse rate is not getting steady with this much only, that means only 120-second orthostatic test or so, that will be an early sign of the overtraining or so. Biochemical changes, of course, as I said, that blood lactate, you see, starts getting decreased, and lactate tolerance capacity, that starts getting decreased. And then, of course, we have the glycogen depletion. People have tried various other biochemical parameters like creatine kinase, urea. Iron levels, yes, should be ascertained because there can be sometimes an iron depletion, serum ferritin levels and ferritin saturation. That, of course, gets affected, that gets altered and needs to be taken care of also. Glycogen depletion hypothesis, of course, is an inadequate energy intake, and it may lead to also to the rise in the pituitary hormones and cortisol and insulin, and also decrease in the resting testosterone and decreased protein and glycogen synthesis. So all this poor subsequent response to training will lead into a fatigue, and the fatigue symptoms may be not only just the muscle soreness or so, there may be even to a biomechanical changes which takes place. That means there is a muscle imbalance which starts over there, various kinds of myofascial trigger points that starts developing over there. There can be even the gauge changes also that can be seen also because of these kind of fatigue elements also. The third hypothesis is as far as the glutamine hypothesis, in which the immunity is getting affected, and that is, of course, inadequate recovery, which creates a glutamine deficient state in the body, and thus we have the can be checked, of course, because from the salivary IgA, which gets decreased, and that's again some people have tried to use this as one of the parameters to see it, but mainly we don't see it in the stage 1 or so. This is normally staged in stage 3 only, where we can do the salivary aminoglobulin or so. There is, of course, a linear relationship with the plasma glutamine and the exercise intensity, and there's maybe a considerable time may be required between the training sessions to allow for the complete recovery of the plasma glutamine. It has been seen that 50% of the reduction of the resting levels in athletes after 10 days overload period is seen with the glutamine depletion, and this glutamine hypothesis thus has gained a lot of ground or so. And this, of course, then there'll be a lot of endocrinology changes. It is considered as a neuroendocrine disorder. And so it is not only the central nervous system which is there, the autonomic nervous system, but your hormonal changes also are there. The excretion of the catecholamines, that of course is getting decreased, and the resting levels, of course, they get increased of the noradrenaline levels, and again further decrease in the maximal cortisol level. The ratio of free testosterone to cortisol again is one of the parameters which has been tried, and 30% decrease, of course, in case it is there, that is a significant to be found to an overloading or so. Mind you, it is just to complete all the various parameters also that we have it also, but as I said, that sometimes it is only in grade 2 later stages, and in grade 3 only that we see it also. Psychological changes we see it much earlier or so. Anxiety and depression, lack of motivation, mood changes, irritability, self-low esteem, and confidence losing is the prime changes that are seen in sportsmen or so. Lastly, the cytokine hypothesis that is saying, of course, that is the alteration in the brain transmitters, especially serotonin, and the peripheral release of the cytokines are important, of course, in the overtraining or so, leading to central fatigue and depression. Of course, there will be a increase in the tryptophan levels, which is a precursor of the serotonin. All of you are aware of it also. So that's a cytokine hypothesis leading to from micro trauma to an acute inflammation and leading to a chronic inflammation, and thus the systemic immune inflammatory response over there. A well-known sickness loop has been there when we have this cytokines flush, which is coming over there and starts getting affecting the central nervous system or so. So thus cytokines affecting it also. That's again the same sickness loop over there. So we have the central nervous system, and that starts affecting both the hypothalamic pituitary adrenocortical axis as well as the sympathetic adrenal medullary axis. And that again can be seen over there once all these hormonal changes are taking place, leading to decreased thyroid stimulating hormones, reduced ACTH, and altered values even to growth hormones or so. And thus there's a reduced activity of the sympathetic nervous system, and thus the whole central nervous system gets affected, and thus the neuroendocrine disorders that we have it also. So all this, of course, continue with this getting affected to the hypothalamus also, and causing more depression in the behavior changes that we have it also. So what are we supposed to do about it? I mean, having known the various hypotheses or so, first of all, I think that the pedagogical methods of recovery are very, very important. Every training session has to be seen. The aims and objectives and tasks of all aspects of the training must be very clear. And that is again for the coaches and trainers and sports physicians to explain it in a simpler language also. And a correct organization of the training cycle has to be there. That means in every micro, meso, and a macro cycles also, then recovery must start in the concluding part of the training session. So every single training session has to be considered as one unit or so. And of course, there are a whole lot of methods of the recovery that we'll see. We just hurriedly will go with the idea was that we do not miss out this kind of an overtraining. And of course, recovery at the best, of course, is to get in the initial stages with a proper sleep and a proper diet and proper psychological state of a mind after we have taken care of all the various causes which are getting affected or so. Medico-biological means of recovery, good living conditions, hygienic, well-ventilated rooms. I am talking of a practical problems, you see, at a lower level. And at the elite level, probably we are able to take care of it. But probably at the state level, in a domestic meets or so, we do not take care of it. And they have to just go into such kind of things without having all these appropriate. They don't get even a single room, or they probably have to stay in a dormitory where 10 people are going to share one washroom only. Diet, pre-game meals, physical therapies, various kinds of physical therapies we have it. All these recovery sessions, you see, must be adopted also. Hydrotherapy, thermotherapy, whether it is mud packs, steam packs, sauna, steam baths, all these kinds of the various we have it. Heliotherapy in form of ultraviolet lamps, depending upon what kind of a climatic conditions that we have it also. Various kinds of electrotherapy, electrosleep, electrostimulation, all these kinds, we must have to use it as a routine in various training methods and the recovery components. So therapy by special movements through music, dancing, that means changing of that training programs coupled with these kind of things. So stretching and bending music with music. I'm talking from a developing country point of view, because there they may not be able to have all these kind of facilities or there, and probably only at the national camps we have it, but we have gone through the various, even the state level camps are there, where the logistics are very, very minimal or there, but we need to take care of this also. So all these are important also, whatever kinds of exercises that we have it. And not to forget that sometimes we do require the help of our colleagues from psychology, and they may have to undergo even psychotherapy sessions, psychoanalysis, relaxation, by be it spiritual, be it yoga, meditation, autogenic training. But these are helpful only if we eliminate the psychic factors that we have it also. That means in case we are not able to sort out their socio-economic causes, or he has a problem with his wife or his girlfriend, or with his department boss or so, or he's probably having it for his promotion, and a whole lot of mental imbalance is there, or leading to a disbalance in the autonomic system or so. So finally, I'll just say that sports science now is a player management and is working in tandem with the coaches. And the key factor about sports science is managing players to aid their recovery and to say when the players can train harder. We know all players have to train harder and harder, but it has to be with methodical training programs and making sure that their people are diagnosed at the earliest and do not let into an overburning or getting them losing such kind of a talent also. Thank you very much. I think that's all that I will have to say. And I'm grateful for sharing it with all of you, and would like to answer in case there are any queries also. Thank you.
Thank you, Dr. Ahuja, for an excellent overview of the overtraining. Next, I request Dr. Vijay Shetty to share his screen. Dr. Vijay Shetty is a consultant orthopedic surgeon, adult and hip specialist from Mumbai. He is the vice president of Indian Association of Sports Medicine, general secretary of Indian Biologic Orthopedic Society. He is a editor of associate editor of CCOT Journal, as well as international examiner for CCOT. He is a member of various editorial board, including international journal. It is my pleasure to invite my good friend, Dr. Vijay Shetty, to give his talk.
Thank you, Aru. Okay, so
Please share your screen, Vijay.
yeah, just a minute. Says Zoom would like to record this computer. No? Didn't I? Okay.
Anyway, we are recording on our thing, so.
Okay, fine. Can you see now?
We don't see your screen yet. Just seeing your photo.
About now?
No.
Just a minute.
Dr. Vijay, please try once more.
So it says meeting locked. Then I've got desktop 1, whiteboard. I pressed share screen and there's an option desktop 1. Share?
Is it your desktop? Can you see?
Yes. My presentation is on my screen. Can you see now? No?
No. So share your desktop, then you can go and click your presentation.
Okay, fine.
The presentation is open, or it's,
Yeah, it's open. It's on my menu bar.
then when you share your screen, go for the option, one more window will be there where you can share your presentation. Have you shared your screen, Vijay? Vijay, are you there? Vijay?
Sir, shall we take some questions, sir? Yes, sir. Yes. Okay. So we'll start taking some questions for the previous speakers. The first set of questions, obviously, for Dr. John on concussions. The first question is from Patrick Pohat from Australia. Dr. John, in your opinion, what is the value of increasing neck strength and stiffness in prevention of concussion? Number 2, bearing in mind the resources required for this, how much value would you place on baseline testing?
Thank you, Patrick. Nice to hear from you again. Also someone who's contributed significantly in the field of sports medicine leadership. The first part of the question, in terms of neck strengthening, there is a body of work which is increasingly showing that it is beneficial. The theory really being, if you can strengthen the neck and slow the inertia of the cranium on the body in terms of impacts, you might decrease the forces transmitted through to the brain. I certainly think there's no harm in it. I would suggest that the neck is one of the areas we don't condition enough for contact and collision sport, and I think it should become standard for conditioning in those sort of sports. In our injury prevention program in South African rugby called BoxSmart, we have a dedicated section to neck strengthening, and I think it certainly makes sense to incorporate neck strengthening exercises, and the research is starting to support that. Some good research coming out of Bath University in the United Kingdom showing that it is beneficial in reducing incidence of concussion. So certainly something I would advocate. In terms of baseline testing, I think that I would look at it in 3 ways. Baseline testing really refers to information you have on your athlete before the concussion occurs, and it's information to which you can compare parameters post-concussion. And I think that takes 3 forms. The first is the type of clinical information you can get by doing the type of SCAT-5 assessment before the season starts and seeing what their sort of baseline pre-injury scores are. The second are the computerized cognitive formats of testing that we have available, the software programs, things like Cogstate Sport, Impact, Headminders, etc. Those are packages which test things like reaction times, information processing speed, short-term memory, etc. And you can get some good information from a baseline point of view and then compare those scores post-injury. And then the third type of baseline information that I think is very useful, but is not that measurable, is just getting to know your athlete. And I think those of us that have worked with teams will know that sometimes you just have a sixth sense after an impact that an athlete is not quite right. And that's why it's so important for team physicians to make this sort of decision, because they have a good sense of when athletes are right. So absolutely very important to get as much background, baseline information on athletes as possible and use that in your comparison post-injury, but don't hang your hat on one particular format. The more information you have, the better.
Thank you, John, for the detailed answer. The next question is from Dr. Siddharth Unithan, a sports physician from Kerala. He just wants to know what are the biomarkers in blood that you would recommend in a concussed athlete.
So at the moment, I don't think we have enough information to recommend biomarkers. And there's certainly not one particular biomarker that I would recommend. And we don't really have the strength of evidence, the weight of evidence that we need to recommend those biomarkers at this stage. So at this stage, I think concussion remains a clinical diagnosis. We're moving in a direction where we will probably have a range of different biomarkers, but you can get a lot more information quickly from a good clinical evaluation field side than you can from a blood biomarker at this stage. We're moving in a direction of salivary biomarkers, which might become more easily measurable and measurable more quickly. And I think that may be an area of research that we're moving towards. But as we stand at the moment, those are areas of research rather than clinical application.
Thank you, John, again. And the third question is from Dr. Grace from the Tamil Nadu Sports University. She wants to know, because there seems to be some overlap in symptoms in women who are menstruating, like the depression, anxiety. Is there some overlap with concussion? And if it is there, how would you differentiate this special situation? Women menstruating and having concussion, things like that.
So I think the point is well made, is that the symptoms of concussion that I put up on the screen are not unique to concussion. They overlap with a whole spectrum of pathological and physiological conditions. So one has to really take on the role of being a clinician and diagnosing the condition. And the first is really the context of what has happened to that particular female athlete. Have they been in a situation where there's potential trauma to the brain that you could suggest, that would suggest that the symptoms are related to concussion, in other words, to a functional brain injury, or are there other reasons for those symptoms? So yes, depression, anxiety, headache, those sorts of things are not unique to concussion, and there needs to be looked at in context and monitored serially to see how they evolve and improve. And so the way you would do that is to assess that patient using a multimodal evaluation and to reassess them serially to manage or to assess the progress of those symptoms and signs and put it into a clinical context.
Excellent.
Dr. Vijay, can we go to his lecture and come back to the questions there again?
Yes, we can do that.
Yeah, I think I made it. Okay. All right. Yeah, I'm so sorry. I think the internet is unstable in this part of the world. Thank you very much, Aru and Tyagarajan. It's been a wonderful experience. Although we're interacting with, can you hear me? Hello?
Yeah, very well. We can hear you well and we can see your slides.
Okay. So This is who I am. I'm an orthopedic surgeon basically, but I do a lot of sports medicine work as well in my institution. And at the Indian Association of Sports Medicine, I work with Aru and other colleagues, which is a very active society in our country. Um, the I mean, the previous three speakers spoke so well. This is slightly out of the context, if you like. The reason being, I'm a surgeon, but I'm not going to talk anything about surgery today in sports medicine. When Aru and Tyagarajan asked me to touch on orthobiologics, it's a very huge topic. There are so many things that we deal with these days, but and if you really look at these different orthobiologic products in orthopedic clinical practice, you start with organic products, you start with synthetic, then you have so many of them. I'm not going to touch any of those because I think today's topic is on PRP. I don't want to go into the details of basic science, but I think we all need to know what PRP comprises of. PRP is platelet-rich plasma, a blood product, and that has platelets and growth factors, WBCs, which is very important for today's discussion, and so many other things. When we talk about PRP, especially a decade ago, or 10 years ago, we were talking about PRP. Everybody used to think PRP is God. PRP is the medicine which is supposed to cure everything. And PRP is something which augments everything, which is actually wrong. Because I think we need to understand that this is which has got so many growth factors in it. Okay. And if you really look at the hello. So if you really look at the products that PRP has, there are so many things which are actually not good for us. There are things that are in yellow which are actually not good for us, which means that we have to be very, very careful when we are preparing a solution for an injection. Before I start, I want to let everybody know that I have been engaged with PRP therapy in my practice for the last 12 years or so. But I want to tell everyone that PRP is not my first line of treatment. Definitely not. So why do I still think about PRP? If you look at a sports injury, let's in general, in a sports injury, we all, physicians and surgeons, start off with non-operative treatment for a start. Okay, we have to give the normal healing process a chance to heal. And during this process, we see there is a chance that some people may not heal, who may end up with operative interventions, and we don't know what operate. I'm talking in general. But I think PRP comes in between somewhere when you have done everything possible under the sun and you don't want to go into under the knife. And in that scenario, PRP is something that can think about. So this topic is not about promoting PRP. This topic is about role of PRP in certain sports injury situations. For me, there are only, practically speaking, two types of PRP. I want to be very, very clear about this. If you look at the literature, it's very vast. You will see pure PRP, you see platelet poor, rich, all that. But we are talking about leukocyte rich and leukocyte poor PRP, which is very, very important, especially when you're talking about sports medicine scenario. I think if you really look at the sports medicine injuries, it's a huge list of injuries. And we don't want to look at each one today because I do not want to confuse you. I think we should be looking at some of the most common sporting injuries we encounter on daily basis. Ankle sprain, patellar tendinopathy, Achilles tendinopathy, rotator cuff injuries, plantar fasciitis, lateral epicondylitis, in other words, tennis elbow, and secondary osteoarthritis, especially the knee joint in the very young, and muscle injuries. These are the ones which I think we should be addressing at this point. So today, as I mentioned earlier, although I'm a surgeon, I am not talking about the role of PRP. There is a big debate about role of PRP in ACL surgeries and in fractures, non-union, especially in sports. It's very interesting. I was saying Thagarajan gave me this topic, and there's plenty of work plenty of time at home. So this is very, very interesting. Look at this graph. Look at this table and see if you are searching for PRP in general on PubMed. You see from where it starts. The situation is 1954, and this is 2020. And if you see, I think we're somewhere in the 70s or 80s, slowly papers started coming out in the literature. Today, if you are searching for PRP in general, I'm not talking about orthopedics, it could be dentistry, it could be dermatology, dermatocosmetology, wherever, but overall, if you see, the use of PRP is gaining popularity. I got 11,770 results just for PRP in general. And I then thought I should look at PRP in orthopedics. Again, 1985, I think the interest started in publications, but actually really, if you see, it's the last 10 years. It's the last 10 years that you're beginning to see. And this is one quarter of, we are a quarter of 2020, and it's increasing. It's not going down.
Yes, sir. Around 905, sir.
Hello?
Automatically record, sir.
Hello? I think you stopped my. Hello?
Vijay, we can hear you. We can hear you.
The slide's not moving forward. And I could hear Thagarajan speaking in the background. So you've done anything from your end?
No, now you're okay. Can you forward your slide, Vijay?
All right.
You just tap your space bar and the touchpad. Vijay, I think probably your internet is maybe not good.
I think so, Aru. I've been having trouble the last 2 days. I don't know. I tried on my 4G, but even that's not.
This can happen only when the internet is not.
Yeah, I agree with you. Do you want to get on with the questions? I'll just re-log in.
Sure.
But we can hear each other, isn't it?
Yeah, but
audio is good.
Audio is very good.
I think he has to reshare the screen again.
Reshare? Okay.
Reshare the screen again, you see.
Let's see.
But probably your slides were not moving ahead, Vijay.
Okay, let me just try that. Okay, I'm there. Thank you very much. Yeah, superb. So that's PRP in orthopedics at the moment, almost about 1,800 publications. Then I thought, okay, today's topic, very, very relevant. And you see this is very important slide. PRP in sports medicine, the interest started in 2006. We are in 2020. Around 2015, if you see the large number of publications in a year, 55 related to PRP, use of PRP in sports medicine. This is when most people got interested in PRP, especially in tennis elbow and plantar fasciitis. So let me just take you through each one just for 30 seconds each. And if you see ankle sprain, I tried looking at around, again, from 2008 to 2020, hardly 55. Now, these publications that you see, they're not level 1 studies, all types of publications, including animal preclinical studies, as well as other level 3, level 4, level 5 studies. So When I looked at ankle sprain, interestingly, this is food for thought. There are no studies at all on role of PRP on chronic ankle sprains. I think it's something that we need to be looking at, Aru from IASM. But there are some studies showing that some people have returned earlier using PRP in acute ankle injuries. Patellar tendinopathy is another common sporting injury. Again, there's not much evidence, very inconclusive. Whatever study that we have, 2 level 1 studies, one is comparing PRP to dry needling, and the other one is comparing PRP to extracorporeal shockwave therapy. So this is like comparing orange to apple. So I think, again, it's not relevant in the current scenario. Achilles tendinopathy, one of the very, very common sporting pathologies, especially in long distance runners. And again, I didn't find anything. PRP use of PRP not recommended by current available literature. I'm looking at only level 1 and level 2 studies. Rotator cuff is another very, very common sporting injury. And again, I didn't see anything that's interesting to recommend rotator cuff, PRP in rotator cuff. Plantar fasciitis, one of my favorites. I published a couple of papers on this one. Personally, I'm a fan, but there are some studies showing role of PRP in plantar fasciitis. Interestingly, this is very interesting. Almost all of those level 1 studies compare, quite rightly, injection of corticosteroids to PRP, because I think traditionally we've been doing corticosteroid injection for almost plantar fasciitis conditions. Now, the trouble with corticosteroid is it may give instant pain relief, but there is a serious risk of rupture of plantar fascia and also atrophy of the fat pad. This is the good one. I think the tennis elbow probably has the best evidence available at this point. I want to highlight on this bit again. This is a little bit out of the context for this lecture, but this is called LRPRP, leukocyte-rich PRP. I'll come to that in a minute. So, and the muscle injury is very common. The commonest muscle injury that we see in sporting, especially in football, is hamstring. And at the moment, we do not have any conclusive evidence for the use of PRP in hamstring or any other muscle injuries. I think we need to include this bit, especially in young people who are in early 30s or late 30s, early 40s, developing secondary osteoarthritis due to chondral lesions in the knee joint. And I think of late, we've had increased interest in the use of PRP, a supplement, a PRP to replace hyaluronic acid. I think it's a very interesting thing actually happening at the moment. This is a very busy slide, but what I want you to highlight here, sorry, I can't use my pointer here, but please see this, the first line. I want you to look at this row. If you see type of PRP, LR, leukocyte-rich PRP, and you see this is not reported, not reported, not reported. This is leukocyte-poor PRP. And here, down here again, you have leukocyte-poor PRP, leukocyte-poor PRP. And you see this one at the end. This is very important. It favors leukocyte-poor PRP, leukocyte-poor PRP. And on top, you see this is leukocyte-rich, but it doesn't favor PRP in osteoarthritis of the knee joint. I draw your attention to author evidence, one of the largest resources for evidence-based medicine orthopedics based out of Canada. And I looked at a paper they published last year, in 2018. What they did was they had 16 RCTs, level 1 studies, comparing PRP to placebo, very nice, PRP to non-operative treatment, PRP to steroid, PRP to hyaluronic acid. You see the most number of trials were comparing PRP to hyaluronic acid. Then surgery alone. I guess surgery is probably arthroscopic debridement for early osteoarthritis of the knees. And what they found was the PRP placebo, PRP did very well at 3 months, PRP did very well at 12 months. Here, non-operative treatment, conservative measures, physiotherapy, and other alternative medicines, PRP did very, very well at 3 months, and there was no significant difference between the two. PRP was the steroid, did 3 months, but then there was no follow-up after that in this group. PRP versus hyaluronic acid, very interesting. In 3 months' time, both groups did very well. I did say, and at one year, I beg your pardon, this is the 3 months, there was no major difference between the two groups, but at 1 year, PRP group did better than hyaluronic acid. And PRP was a surgery, so obviously it's, I think, arthroscopic debridement. Again, at 3 months, no difference. At 12 months, again, no difference. So this is not recommended, something that we could check in your practice, and this is only for short term. And this is the paper that I just saw 2 days back in the American Journal of Sports Medicine, 17th April, 3-4 days back, by Jason Dragu's group from Colorado. He's now in Colorado. So again, they looked at 18 level 1 studies, PRP versus only viscosupplementation. How interesting. You saw the ortho evidence papers. They looked at saline and other placebos or other comparators. But here, this group looked at only level 1 studies. 18 they found which met their inclusion criteria, and they followed them up for 11 months. And PRP group did significantly better. Look at these people. This group is osteoarthritis grade 1 and 2, who are still in sports, still performing. And again, here, this paper is also very clear that leukocyte poor PRP had a superior performance compared to leukocyte rich and hyaluronic acid. I then looked at, see, we have to, at the end of it, recommend something for our viewers and our colleagues. Nice guidelines from the UK. And this, just a couple of months back, I logged in, and NICE has actually taken PRP treatment on board at this point, which is a good news. But they warn that, you know, there is no problem with the safety of using PRP in clinical practice. Efficacy, we still don't know. The recommendation from NICE at this point is that you sit with your patient, spend a lot of time just to make sure that you're doing the right job and good job for your patients, and take a fully informed consent. If they're okay with it, go for the treatment. Right. Well, so my recommendation at this point is, after doing so much search, I personally feel, and also there's good high quality evidence, tennis elbow, go ahead, no problem. There is a small error here. This is not Achilles tendon. Just a minute. This has to be osteoarthritis again. So there's a spelling mistake. Okay, sorry, I was just changing. So tennis elbow, yes. This has to be early osteoarthritis. High quality evidence, yes. Patellar tendinopathy and plantar fasciitis, yes, they're safe. They have good efficacy. There is moderate high quality, which is reasonable, okay, but you have to take it with a pinch of salt. You have to again sit with these patients and talk. Remember, you're dealing with people who are performing at highest national and international level. Okay, so now this is real Achilles tendinopathy. So osteoarthritis is in the previous slide. Again, there is safety-wise, I think there are no concerns. Almost all of these conditions. Efficacy, we're still looking around. Quality of evidence is very low. So recommendation at this point, I think, I'm not sure. Summary, platelet-rich plasma in sports medicine. I think the first thing that we need to know as physicians and surgeons, that this should not be, and it is not, the first line of treatment, full stop. Safety, yes, there is good evidence. Efficacy, I think it's indication specific. As I mentioned, people with tennis elbow and early osteoarthritis are doing very well. And we have to use this with informed consent. We have to sit with the patients and discuss the pros and cons and take it on board. And take home message here for most people who are still confused with different preparations of or formulations of PRP, that at this point, I can tell you, if you're using PRP for a soft tissue problem, tendons, ligaments, I think leukocyte rich is preferred. If you're using PRP in a joint scenario, I think leukocyte poor plasma is preferred. Thank you very much for your attention. Sorry about the technical glitch.
Thank you, Vijay, for a clear message on the PRP usage in the sports injuries. And now we can go back to the panel discussion. Dr. Tyagarajan, can you take some more questions?
Yes, sir. There have been a lot of questions. In fact, close to 1,000 people watching it live, this webinar. So I'll just take only a few important questions for all the panelists.
But rest of the questions, we can get the answers from the respective panelists.
Yes.
And send those answers to the those people who asked, also put on our recording. So
Yes.
later they can watch.
We'll try to do that, sir. And the next set of questions go to Dr. Peter Brukner. Doctor? Yeah. The first question is from Mr. Arnab Das from Sports Authority of India. He is asking, there are a lot of studies and controversies with head injuries, especially in American football and English Premier League. And they have recently issued guidelines on practice of headgear in younger age groups. So where do the Olympic sports like boxing stand there for a reasonable cost to look into the impacts of sports? So he wants to know about the Olympic sports of boxing and what is the status of headgear there?
Well, I mean, the Olympic boxing, amateur boxing, has always been performed with headgear, unlike the professional counterparts. And there are a lot of differences between amateur boxing and professional boxing. Headgear is one of them. The length of the boxing match is very different. The length of the match is very different, and also the referees are much stricter in amateur boxing.
Thank you.
So it's a much safer sport, amateur boxing.
Okay.
As far as helmets go, I think the helmets have always been used, as I said, in amateur boxing, and they will continue to be. Whether they should be used in professional boxing is a moot point. I mean, I think they probably should, but I think in amateur boxing they'll continue to be used, and which I think is a good thing.
Can I just comment on this?
Please go on.
Yeah, you see, as far as the amateur boxing is concerned, the headgear has been removed already. But again, the latest information which we have just got it last month only after the Intercontinental Commission meeting, that they're probably thinking of bringing it back. There has been always a big uproar in the British media as well as in the Australian media about the use of amateur boxing, actually boxing to be dropped over there. I, having worked in boxing for a good 20 years, even I also asked about this. I have always been saying that yes, headgear must be used. Now they had removed it, and during the W series of boxing also they had started not using it. And also the second question is also about the 6 weeks mandatory rest, which is given arbitrarily, and the 4 weeks after the RSCH also. So this is a big matter of debate as far as the boxing is concerned, Peter, according to me.
Yeah. Yeah. No, the mandatory rest after a knockdown, isn't it, or a knockout loss? When you, yeah. I mean, in the ideal world, you'd have proper ways to assess their recovery from that, but in many instances, we don't have those facilities. So it's probably not an unreasonable thing. Why you'd pick 6 weeks instead of 4 weeks or 8 weeks? It's, that's, you could argue that, but I think a mandatory rest is not a bad idea.
Yeah, thank you, Doc, and thanks, Dr. Ahuja, for the interaction. And the next question is for Dr. Peter Brukner again. Dr. Guru from AFMC Pune, he wants to know, as an young sports physician, do we have to focus more on injury prevention and performance, or injury management? So that's a dilemma of the young sports physician. Dr. Brukner, how would you advise?
Look, I think they're both important. I think that's what's so attractive about our field of sports medicine. It's such a broad field. I mean, I think when I first started in sports medicine, I thought it was all about injuries. and all about managing injuries. But the further I've gone in my career, I think the importance of prevention, the importance of exercise, of promoting exercise, of promoting various lifestyle issues for health, it's become much broader than just injuries, which makes it far more interesting, I think, than that. And I think, sports physicians are ideally placed to be, we're the experts in exercise. And so, really no other area of medicine specializes in exercise the way we do. So I think, it's such a broad field we have now. Injury prevention is very important, very challenging. And obviously, there's more and more work being done, more and more research being done in injury prevention. And I think that's one of the areas that's going to grow a lot in sports medicine.
Thanks, Doc. And the last question for you, but there are dozens of more questions pouring in for you, but we will let you go with this last question. And this question is actually more general. Dr. Grace, she has asked, how do we generally improve the cordial relationship between the sports physician and the coaches and the support staff?
Well, as I showed in my talk, there's sometimes they're not so good. I think it's a matter of trust, and you have to work on gaining the trust of the coaches and your fellow staff. And so I think that the first way I do that is that I make it very clear that my first priority is the health of the athlete, and it always will be. And I think you've got to be very upfront with them. There's a lot of pressure on the doctors and the coaches for performance and for winning games and so on. But ultimately, we are there as the players' representative, if you like. We're the only one who's really, their health is our first priority. For everyone else, it's probably not their first priority. So we have to be advocates for players with the coaches. And I think, ultimately, if you're consistent with that and you communicate that well with the coaches, then you'll gain their respect. They may not agree with you all the time, but at least they will respect what they're doing. I think you also have to be realistic and speak to the coaches and say, yes, you want to help the team perform well too. You want to help the individual players perform well, and you'll do everything you can to help that performance with injury prevention and with getting players back onto the pitch as quickly as possible. So you're both on the same side for most of the time, but there may come a time where the coach has to accept that they've got to take the medical opinion that the player cannot continue playing. So it's really a matter of respect, and we've got to earn that respect.
Well said. So the final few minutes, we'll push a couple of questions each to Dr. Ahuja and Dr. Vijay Shetty. Thanks, Dr. Brukner. And
okay, good night. It's past my bedtime. I better go.
Thank you so much, Dr. Brukner. And we enjoyed your presence, and it's a great honor to have you with us. Thanks again.
Honored to be there. Thank you very much.
And we'll be sending the questions, rest of the questions to Dr. Brukner and get his answers. And now to the questions to Dr. Ahuja. Questions from none other than Mr. Bhaskaran, who is our Olympian and gold medal winner in hockey. Sir, thanks for joining the webinar. Sir has asked, there are sometimes very less time for recovery in hockey. For example, only 16 players are there in a squad, and there is sometimes only less than 24 hours for recovery. So what is the advice from your side, sir?
Well, I think Bhaskar and I, of course, we have worked together in 1980, you see, when he was the Moscow Olympics captain, really proud and a great sports person. Bhaskar, I know it's a very, very practical problem that we have faced in the game of hockey. And my advice always is that I know the sports staff is always insufficient. You may have, these days at least, you may have probably one physiotherapist and one masseur along with that. So the key for this is that the athletes have to be told as to what are the various methods that they can use it over there. Every athlete knows how to recover himself over there. Well, of course, the hydration, the diet, all those are important things, which is for the general nature also. But rest, every individual, somebody just does some prayers, and he feels relaxed with that only. You see, in a team game, when we got only 24 hours to recover for the next match also. On the other hand, somebody is just watching a television also. So that's why I gave a complete list of these things, you see. And again, sports physicians are supposed to know about it, that which athlete is fond of doing that particular thing. He may just do a little meditation, spiritual meditation. It has to be an individualistic approach, and we cannot follow it that for all the 16 people, the same thing will work out also. So the best answer will be that every athlete must know about it and should follow that proper under the supervision of the coach and the sports physician.
Thank you, sir. And thanks, Mr. Bhaskaran, sir, for the lovely question also. And the second and last question to Dr. Ashok Ahuja, sir, is from, again, an young sports physician, Dr. Sai Aditya. He wanted to know from you, sir, what is the role of the new technologies like the wearables, athlete monitoring systems in India? How do we stand? Where do we stand?
Well, I think we have now started it about there. Say, if I say particularly in my talk, you see over there nowadays, and all the elite teams, of course, we are using it. The GPS system also is being used more from the technical point of view, but also at the same time, we are able to assess as to how much is the load that we are able to give it over there. So all these, and even the sleep trackers are also there. And when we say sleep and performance is a very, very vital, important over there. So all these kind of variables give us a lot of input over there, and it's very easily can be taken. You see, all the data can come into the sports physician's smartphone or into the coach's smartphone as to how has he slept it over there, what is his wake time over there, what is the quality of the sleep over there. So certainly, but I'm saying this is happening only at the elite level. Unfortunately, at the national levels, we have still a long way to go over there, when our sports people shall be able to use it also.
Okay. And the final question from Dr. Grace for you, Dr. Ashok sir, is about women in sports. What is the hormonal imbalances that can affect their sports performance, and what would be your comment on that?
As far as the women are concerned, well, it's a well-known conditions that we have it in sports, and we see it very regularly over there, whether it is an athletic amenorrhea, whether it is a delayed menarche that we have it also. We should not panic in such situations also. I have seen from my experience, gone for the various international competitions, missing of one period or so, or having an oligomenorrhea does not mean that you just start putting them onto various kinds of hormones or estrogen progesterone combinations and start with that. It's only in case it is prolonged something or so, for example, a menorrhagia persisting over there and leading into an iron deficiency kind of a thing. Such, of course, problems. The problems are there. And then another very big problem that we have always tackled or needs to be tackled is regarding the clashing of the dates of their menstrual cycle with the competition or so. So whether there has to be a preponement or a postponement. I have always recommended that it should be preponed, but that will require at least 3 to 4 months of prior planning, so that the whole period is shifted over there, and that is only when we know about the calendar or so. So there are quite a number of problems, and I should not be calling it problems. This is a normal physiological phenomena, but it needs to be understood by the sports physicians fully also.
Thank you so much, sir. And finally, a couple of questions to Dr. Vijay Shetty. Thanks for the lovely lecture. And Shubham and one Mr. Praveen, they want to know, what is the success rate of PRP? Should it be done always with an ultrasound? And do you recommend it for the Osgood's Clutter syndrome? 3 questions, in fact.
You got to unmute the Vijay. We're not able to hear him.
Can you hear me now?
Yes, Vijay. Thank you.
Yeah. Thank you, Rajan. Yeah. Now, answer to question number 1. is what is the success rate? It's a very difficult question to answer, simply because we are looking at indication-specific PRP formulations. When you look at the indication-specific formulations, like I mentioned, there is leukocyte-rich and there is leukocyte-poor. I mean, there are different formulations available. What information we have at the moment from the literature is whether there is evidence to show that it's recommended or not. We do not know yet what is the success rate. I don't think anybody is, you will find so much information on that one. So as I mentioned, if you are dealing with tennis elbow, I think go ahead, because this is so important, because especially in our country, when you embark on PRP treatment, there are a lot of legal issues. And as we mentioned earlier in our IBOS meeting, injection of PRP, again, it has to be done with special precautions. So if you are asking me the question that what is the success rate, I can tell you, look, going by the literature, there is, with evidence-based medicine, I think go ahead with tennis elbow and for the knee. Plantar fasciitis and patellar tendinopathy, I think there is evidence, but it's medium quality. So you can still offer. Other indications, I'm not sure. So the second question, Tyagarajan?
In Osgood Schlatter disease.
Really, it's a very good question. I have not found anything on OS disease in the literature. There is patellar tendinopathy, which we are talking about, the tendinopathy at the origin of patellar tendon, at the inferior pole of the patella, not at the distal attachment. So that is something that I'll have to work on. But at the moment, I don't know. The answer is no. The third one, what is the third question? Whether
it has to be done always with the ultrasound.
So this is very interesting. I met there's a very famous foot unit in Leicester foot unit. For plantar fasciitis, the gentleman, it's a friend of mine, he said that he was doing every plantar fascia injection under ultrasound guidance. Now let's look at when you want to do an injection, especially PRP, you want to do it at a place which is most tender. There are people who do. I have no experience with ultrasound, but personally, I feel it's probably not required. Obviously, we'll be looking at the most tender spot, and we don't want to use another machine and make the area vulnerable for infection. So that's my opinion. But looking at shoulder, especially, I think there is a lot of information about injection into rotator cuff injury. Most of us are worldwide. People are doing injection at the moment into the subacromial space, because it's very difficult to get to an area where there is a damage to tendon. So in shoulder case, probably it is relevant, because you can actually go into the area, see the damage, and then inject. So there is a role for ultrasound, but again, it's indication specific.
Thank you, Dr. Vijay. So there are hundreds of questions pouring in. So we'll collect all the questions and send to you all the faculties, and please try to give the answers. So we'll probably have a collective question and answer bank here. Thank you, sir.
Thank you.
Thanks again on behalf of IASM for taking part in the webinar. We'll have 2 more webinars coming days, and especially thank our international faculties for sharing their time, and see you again tomorrow. Thank you.
Thank you.
Thank you. Thanks a lot. Well,
Thank you. Thank you very much.
But it needs to be understood by the sports physicians. Thank you so much, sir. And finally, a couple of questions to Dr. Vijay Shetty. Thanks for the lovely lecture. And Shubham and Mr. Praveen, they want to know, what is the success rate of PRP? Should it be done always with an ultrasound? And do you recommend it for the Osgood-Schlatter syndrome? 3 questions, in fact.
Unmute the Vijay. Not able to hear it.
Yes, Vijay.
Can you hear me
Excellent.
now? Yes, Vijay. Thank you. Yeah. Thank you, Rajan. Yeah. Now, answer to question number 1 is
No worries. Yeah, always technique always has a challenge. Yeah, it was excellent. Close to 1,000 people joined, and questions are pouring in. Lots of athletes, coaches, everyone joined. Sure. Yeah, we can do that. Thanks, Vijay. Thank you so much. Bye-bye.
thank you. Thanks a lot.